Good afternoon, everyone. We are here in our last session for the day, and I'm happy that you're able to join us for coronary scanning and hands-on live workshop. I would have loved to join you in person, but I would really like to thank Dr. Dada and Dr. Harashi for stepping in last minute to take my role, and also the faculty, Dr. Al-Gindi, Dr. Al-Koli, and Dr. Saleh for participating in this workshop. I have no disclosures. I would like to start the workshop by going over, by echo, how do we qualitatively and quantitatively evaluate coronary artery lesions, and what are the basic echo views in coronary imaging before you actually see live scanning and you get to practice. So the workshop will start at 2:20 and will end somewhere around 5 p.m. There are two stations. We have live volunteers. Some are healthy, some have aneurysms, and our faculty were mentioned earlier. We have 5 faculty. Thank you for participating. So as I said, the goals of the workshop is to understand the optimal acoustic views needed to evaluate the coronary segments. The faculty will go over knobology needed for image optimization, how to we illustrate measurements of luminal dimensions on echo, how to look for small, medium, and giant aneurysms, how to detect thrombi, and identify luminal myointimal proliferation. Aneurysms can be qualitatively assessed by looking at them, and we can decide whether they're saccular or round, fusiform or tubular, or spindle shape. Often saccular have worse outcomes than spindle-shaped aneurysms. When we look at quantitative assessment, which has been adopted as a way to risk stratify and to um, assess coronary arteries, we take the absolute luminal dimension, inner edge to inner edge, and you want to avoid measuring at the origin. You want to measure 3 to 5 millimeters away from the origin of the left main or the RCA, and you want to avoid branching or bifurcation points, as they often tend to overestimate the size of the artery. You have to just be careful, though, that you look at, for example, the angle at the area of bifurcation of the left. You want to make sure that it's an acute angle and not an obtuse angle, because often if there is an aneurysm at the bifurcation, it is wide and the angle there is either effaced or quite obtuse. And then those measurements are taken and normalize the body surface area to come up with a z-score. And that's what as I mentioned in my talk on multimodality imaging, that's what the AHA statement in 2017 has adopted as a way to classify coronary artery aneurysms and risk stratify them. And the Japanese guidelines in 2020 did that as well. So, and as I mentioned, the z-score is the number of standard deviation from the mean. I wanted to mention, though, that the reason we optimize our images on echo, it's not only to actually see the aneurysm and detect how many aneurysms we have, but also because we want to get the optimal measurement possible, because small errors in measurement can translate into a larger difference in z-score and can make an artery go, instead of being a small aneurysm, be a medium aneurysm. And also, it's important, since body surface area is part of the equation, to get an accurate height and weight on our patients. When imaging children with Kawasaki disease, you will need the highest frequency transducer possible, because you're looking for higher spatial resolution. You want to make sure you acquire movies and not still images. You might need to sedate children that are younger than 3 years of age and those that are uncooperative. At my institution at Mount Sinai, we obtain at least one sedated echo on a child with Kawasaki disease at either their acute presentation or in the subacute period, and we use pentobarbital 5 per kilo, and we do this in the echo lab, and we have a sedation nurse. You want to drop the gain, followed by the dynamic range. If you are using certain machines, they have that dynamic range button, and you want to drop it below 50. Usually it's set at 50 and you want to drop it below. You want to set the focus on the coronary artery that you're looking at. You want to make sure that the frame rate is above 20 to increase your temporal resolution, and that the echo beam is directed at a right angle to the artery. And when you look at this parasternal short, you actually see, for example, here the left main LAD and the circ. You see the aortic valve, but you're not truly at the level of the valve. You're really at the level of the sinuses here. So if you actually see the valve on a parasternal short, if you slightly tilt anteriorly or superiorly, you will actually open up the coronary artery. Persistence is often low or off. When you use color Doppler, drop the Nyquist limit until you start filling the coronaries. Usually it's in the 30s. You don't want to go lower than that. You want the color to hang in there, but you don't want it to bleed. So you want to make sure that the color gain is increased to fill the artery, but not enough to cause bleeding of color outside the vessel. So starting with a parasternal short, as I mentioned, for example, in this view, we see the pulmonary valve anteriorly, we see the aortic valve more posteriorly and rightward, and you're really, as I mentioned, not at the level of the valve, but at the level of the sinuses or the roots. So you've tilted superiorly. And in order to open up the LAD, you need a clockwise rotation. So you'll see the left main, the LAD, and the circ. And you fill that with color. So you see that the left main, the circ that dives posteriorly into the left AV groove. Make sure you don't confuse that with any of the marginals that would go anteriorly, and then the proximal LAD. And you actually see that the proximal LAD is proximal to that pulmonary valve. If you move further, more superiorly on the chest and slightly leftward, you will actually see the distal LAD, which is distal to the pulmonary valve annulus. This is the pulmonary valve annulus, and this here would be your distal LAD as pointed by the arrow. Um, Also, you can see if we move on to a parasternal long axis, and you angle towards the left to the right ventricular outflow tract, you would see the proximal LAD coursing into the interventricular septum, and you can see the circ diving posteriorly into the left AV groove. This is the LAD, and this is the circ diving posteriorly into the left AV groove in a patient who actually has dilated coronary arteries and has actually an aneurysm in the LAD. Going back to parasternal short and focusing on the right coronary artery, in that particular case, you'll have to rotate anti-clockwise to open up that right coronary artery. And you want to see the right coronary artery, the proximal right at least, as it I'm going to play this again, but you want to see it course into the right AV groove. You don't want to only look at the origin, but you actually want to follow it into the right AV groove. Um, and then going to a parasternal long axis, you see that this is a parasternal long axis, I apologize, not a short axis. You actually see, if you angle in towards the RVE, right ventricular inflow, you see the tricuspid valve and the right ventricle. You see in the right AV groove the mid right coronary artery. And if you follow it, you want to make sure that you're not looking at the liver heart interface. You see the posterior descending artery. And usually what we do is we look at the mid-right coronary artery and we follow it into the posterior descending. We follow it, we track it, and it would lead to the posterior descending. Going to an apical view, if you go from the apical four-chamber and you angle posteriorly, you will see the distal right coronary artery traversing into the right AV groove. You want to make sure that you're not angling anteriorly because that would be the proximal RCA. And then if you angle, and then if you look into your interventricular groove, you will see your distal LAD into the posterior, going into the posterior interventricular groove. And then finally, if you go to if we look at the left AV groove, also angling posteriorly, we see that this patient actually has this is the circumflex coursing into the left AV groove with a kind of an aneurysm within small aneurysm within the circ. And when you angle posteriorly, you get your left AV groove and you actually can see your circumflex from here as well, and you see how dilated it is. When we look at coronaries, we're not just looking at the number of aneurysms where they are located, but we're also trying to see if we can find coronary artery wall changes. This is a patient with this is a child with giant aneurysms. You can see at least two saccular aneurysms in the proximal and distal LAD, and you can actually notice how thick the coronary artery walls are. They're quite thick, and when you put color, you see how the color shoots through the coronary artery. And this is a coronary artery wall change when the myofibroblasts invade, kind of proliferate and invade the lumen. This is uh, part of the healing process, if I may say, of the coronary artery in Kawasaki disease, or um, the way it actually kind of heals, I guess. You can see that these patients not only have aneurysms but have this myointimal proliferation, and that puts the patient at risk for stenosis in the future. In this same patient, 6 months after this, or a year after this echo, you can see has developed an actual thrombus within the proximal LAD. You can see this echogenic mass in the LAD, and it actually has completely obliterated the proximal LAD lumen. So, in summary, we went over how to evaluate coronary arteries in Kawasaki disease children by echo. Why do we quantitatively and qualitatively assess them? And what else do we look for other than evaluating the size of the aneurysms, their number and location? And we looked at some of the coronary artery wall changes that occur. So following the talk, the faculty will direct you to the stations and the actual live scanning of the workshop will begin. Thank you, and I'm happy to answer any questions.